Thank you very much for the introduction. And so one of the things that the vision that we have for this Australian Cannabinoid Research Centre that Ian alluded to earlier, where we're going to try and bring together all of the top experts that we have in Australia, in New South Wales, to hopefully form a dedicated cannabinoid research group, is to enable us to reach out and interface with you guys and draw in the information that you've got and turn it into the type of information that is required to legalize medical cannabis. Because what you're talking about in this forum, all of these case studies, as compelling as they are, it will not get medical cannabis legalized in the formal route of the TGA processes and therefore enable it to be available to doctors. So we see our role as a potential outreach for you to come to us, and we can work with you to turn your data into published papers that the peer-reviewed community out there in the world can pass comment on and tell us whether they think it's good, it's biased, or it's unbiased, and that's the way that we want to move forwards. So in this talk today, I'm going to give you a flavour and an overview of the way the system works right now. Maybe the system needs to be changed. That's not what I'm here to talk about. I'm here to educate you on the way that the system works right now, and if you want to get into the system and have your drug of choice available, you've got to play this game right now. So that's what I am here to tell you about. And I just want to start by thanking Lucy and Lou for the opportunity to come up here. I rode my motorbike up and had a really nice time seeing some beautiful scenery on the way, and it really is a beautiful part of the world. And Lou didn't think the New England Highway was a particularly impressive motorbike ride, but I've got to tell you, when you live in Newtown in the centre of Sydney, it's bloody lovely. So how do we get a drug approved for medical treatment? The drug development pipeline. This is the way it normally works. So I don't know what the slides haven't been too good, so I hope you can see it. But if you look over on your far left, you'll see, really it's entailed in the arrows up at the top that are going across the screen. So the one on the far left is preclinical, and that is research that takes place in a lab, in a Petri dish, with cancer cells in a Petri dish. Ian's work with the rats in his lab, that's the preclinical work. And that's what a lot of the anti-cancer work that's been presented here in the last 2 days operates in that preclinical domain. Notwithstanding the few case studies and very compelling case studies of individual human subjects who've been treated with it, the majority of the evidence base that is published in the scientific literature, peer-reviewed by our peers out there, in that space is in the preclinical domain. Most drug developments start in the preclinical domain, of course. But once we've found a promising line of attack, a promising avenue of research in the preclinical domain, you move into what we call phase 1 clinical trials, which is the second arrow from the left. And they're the first in human clinical trials. So really what you're doing with the first in human trial is you generally use healthy subjects, so you don't go into clinical populations who are vulnerable and you don't want to do any damage to them. You use healthy subjects and you administer the new drug, the potential new drug, and you're looking at safety of using the drug with those populations and tolerability. And you do a lot of toxicity testing, genetic toxicity, and repeat dose toxicity testing and all that sort of stuff. Fortunately, Sativex has been through this process, so we already have a lot of this early data for cannabinoids as a medicine. And yes, it's been used for 5,000 years and all of that, but those 5,000 years were not in the format of trial that removes bias and all of that sort of stuff. So it's not going to be used as evidence for getting a drug into the modern medical pipeline. So after you've done the phase 1 safety and tolerability, you move into phase 2, which is with treatment-seeking populations, people with epilepsy, people with the cancer, nausea from cancer and all that sort of stuff. And phase 2 trials are generally quite small, and they're looking at the direct efficacy of the drug. So does it work for the indication that you're interested in? And they can be, there's all sorts of phase 2 trials, but the ultimate that you're looking at is the gold standard is a randomized controlled trial. If it's successful, if it looks like it works for the treatment, then you move into a phase 3, which is a much larger scale outpatient trial. If the results of phase 3 are promising, it finally enters phase 4, which is going into the market. It's approved, it enters the market, and then we do what's called post-marketing surveillance, which is continuing to gather data out in the community, looking at adverse events, looking at efficacy still, and that is basically the drug development pipeline. Within the human clinical domain, there are levels of evidence. So I've heard a lot of talk about there's 900 papers about cannabis killing cancer, there's 20,000 papers for cannabis doing this and that. My question is, how good are those papers and what is the level of evidence? Are they open label trials? Do the people know what they're getting? Are they blinded? Are they biased? These are the questions that me as a scientist that I ask when I'm presented with a piece of evidence. So this is how the National Health and Medical Research Council decide they want their evidence to come to them. And it's the National Health and Medical Research Council who the TGA listen to when they decide whether a drug is going to be used for a particular indication. So I don't know if you can read it. I just pulled it off the internet late last night. Didn't have time to tidy it up, but basically what you're looking at, over on the far left is a column called intervention. And they're the types of studies where they're the types of studies that are most relevant to cannabis in the medical domain. We want to get in there, administer the drug as an intervention for a particular illness and find out whether it works or not. All the others to the right are different types of studies looking at prognostic utility, observational studies, so that's a lot of the type of work that we've been hearing about, where you're just watching something happening and not doing any actual intervention. You're just watching people using it and making observations. Within that column on the left, the interventional studies, these are the ones that ultimately need to be done to get a drug into the modern medical pipeline. You can see there's a number of rows in the table. And those rows are in order of increasing evidence. So at the very top, you've got systematic reviews of randomized controlled trials. So that's a meta-analysis where you take the results of these gold standard trials and you put them all together. You have 10 trials on cannabidiol for epilepsy, if only we had the data. And you look across those trials to get an idea of whether it works across multiple settings. Below that is the randomized controlled trial. And as you go down, you're going down in the grade of evidence that the NHMRC will consider as useful and appropriate for passing a drug off as potentially useful. And at the very bottom there, in the red square, you've got case series. So case series are what are thought of as level 4 evidence in the NHMRC scheme. And they're really what we've been hearing about here. So the video of the people in the nursing home taking a bong and their hands stopping trembling, that's a case study. So you're basically going in and you're administering, the person knows what they're getting, so they potentially could have a bias as a result of knowing what they're getting. You know what you're giving them, and you just do it and you observe them. So it's not blinded, it's not randomized, and that's the lowest level of evidence, and then you can move up the evidence hierarchy. So just to put things in perspective, we've heard a lot of talk about Petri dishes, preclinical, mouse work, and case studies, but we're not hearing a lot of information about randomized controlled trials or anything like that. Now, what we think we can do in this Cannabinoid Research Institute is to take your information that you're all so frustrated about having, and help you to turn it into some format that will be in the language of the people who pass the regulations. So it doesn't necessarily have to be a randomized controlled trial. There are cases where randomized controlled trials are too difficult. Maybe the condition that you're interested in is too rare, and you couldn't get the numbers that you need to do a formal double-blind randomized controlled trial. Well, the good news is there are many other research designs that you can do to utilize data in those circumstances. And we are experts in helping you to take the information that you've got. It might be case series. We can do gather multiple case series together and synthesize it like that and turn it into a format where it can be published and peer reviewed and potentially help to move the movement forwards. So moving on to the work that we do in our lab, the work that we do with humans, and really, as Ian said, with Psychopharmacology Lab, we do a lot of work with Nick, who's in the discipline of addiction medicine, and we have traditionally done work on addictions, and I'm going to tell you a little bit about the trial that we did treating cannabis dependence. And I know there's going to be a lot of naysay out there and a lot of people saying, but there's no such thing. Nick's going to cover that when he gets up, and I will just say, these people are presenting to us asking for help. We're not making it up. They're coming to us and saying, I can't stop smoking, I need some help. So just thought I'd put that out there. That is the rationale for the work that we have done. But really what I'm doing here in talking about this trial, I don't want to get into the arguments about whether there is or isn't a dependence or a withdrawal syndrome. That's not what I'm here for. What I'm here for is to talk about the trial that Mike Baird has announced or is about to announce, and what it actually is like to run a clinical trial with humans administering cannabinoids in New South Wales, because that's what's on the agenda, that's what's coming at us thick and fast, and we want to be ready, we want to do it right, and we've got the expertise here in New South Wales. So I'm really talking about the process rather than the political arguments or whatever your personal beliefs are about the study itself. So the trial process. This is a window into my job. This is what I do at work at Sydney University. I basically run clinical trials. And this is the trial that we did with Sativex. So it started, I'm going to give you the timelines to paint a picture of what a big deal it is to do a clinical trial in humans with cannabinoids. So the first thing we have to do is obtain funding, and that took 15 months in total from originally sitting around in the pub thinking of an idea and eventually getting money from the NHMRC to do the work. That was 15 months. It was 9 months from submitting the grant proposal to the NHMRC to them funding it. And as I worked through this morning, I realised 9 months is the incubation period of a human child, and there's my kids. I just thought I'd put that up there. And after you've got funding, you have to write a clinical protocol. You turn your grant proposal into a clinical protocol, which is like a manual that goes into a hospital or into the treatment facility where you're going to do your work. And it details every single thing there is you need to know about this trial. It's got all the ethics in, it's got all the data collection processes and all of that. Once you've got your protocol, you submit it to a Human Research Ethics organisation, and they take it away to a committee and tell you eventually whether they're going to approve your trial. Often they ask you to make changes to your proposal, and then you have to go to your individual sites, if it's a multi-site trial, and get permission from those as well. And that process took us 7 months in total after we got our grant in the bag. Then you have to go to the Therapeutic Goods Administration and submit a clinical trials notification and get approval from the Therapeutic Goods Administration to do your trial. That took 2 months. And interestingly, at the time in 2011, Sativex was so new on the scene to them, they didn't actually know how to classify it. And after they gave us approval, on June the 6th, they then emailed us an urgent email on June the 17th telling us to cease and desist all activities in the clinical trial. We'd received incorrect advice and we weren't allowed to do it. But then they backtracked and changed their mind 2 weeks later. After you've got approval from Therapeutic Goods Administration, you have to go to, in New South Wales at least, the Pharmaceutical Services branch of New South Wales Health and get permission from them, and that took us a month. After you've got permission from them, you go to the Commonwealth Office of Chemical Safety and get permission to import the cannabinoids, because we don't produce any cannabinoids here in Australia for medical reasons. And that took 3 months. And then after that, we had to get an export permit from the United Kingdom export people. That took a month. And then finally, we could run the trial. And that took 12 months of hell. The first patient was processed December 2011 and the last November 15, 2012. And then it took us 12 months to analyse the data and publish it in a peer-reviewed journal. So in summary, the clinical trial process takes about 3.5 years from the initial idea to the last patient being processed, so the data collection. From last patient process to publication, about 1 year. So you're looking at about 4.5 to 5 years to run a single clinical trial of cannabinoids in humans in New South Wales. That's one trial for one medical problem for a 1-week cannabinoid treatment for 51 people. So what is Mike Baird's working party going to deliver at the end of the year? I've just listed a bunch of questions that possibly I predict they could deliver one or multiple of these suggestions. I will point out that the top 3: does cannabis improve neuropathic pain in cancer treatment? Does it improve nausea and vomiting in cancer treatment? And does it improve wasting disease in cancer treatment or in AIDS? It certainly does, and we already have the clinical trials on that from America, so I'm hoping that that is not what the working party suggests, because we've already done it, and we could easily be going ahead with some form of regulatory system to enable access for that. Does it help with childhood epilepsy? We don't know. Obviously, the anecdotal reports are very promising. There are no clinical trials, and we desperately need them. Should be a priority. Does it kill cancer? No clinical trials. Anyway, the point that I'm trying to make is, look how many possible opportunities we could have delivered to us as a place to go when this working group report. There's a lot of things to try. And as I've just shown you, you're looking at about 5 years from go to finish. So that's an awfully long time, but the work is very important and it needs doing. So what can we do to move things forward in the meantime? Well, let's start with legal protections for terminally ill people and for the epileptic children, as Mike Baird has already done in New South Wales. I would like to say that every other state in the country now needs to follow suit immediately. I don't know how the law works or anything like that. I'm a geeky scientist, but a federal mandate maybe, or basically we need, I was talking to somebody, a father of a 2.5-year-old child with epilepsy last night at dinner, who's from Melbourne, I believe, and they don't have these exclusions set up in Melbourne, and I could tell there was an air of desperation there. We really need to make sure that these exclusions come into play immediately. And then we need to ensure that the right people with the relevant knowledge of cannabinoids, cannabis, and the drug development pipeline are involved in these trials as they come to light. Thank you. None of us know who is on the committee at the moment, and none of us cannabinoid researchers have been invited to be on the committee. So it's not cannabinoid researchers making these decisions at this point in time. Maybe quicker, if Australia produces its own medicinal cannabis, is that such a scary idea? Well, this is what it looks like in England. So this is GW Pharmaceuticals' grow setup, secret location just outside of London, one of the biggest cities in the world. Secret location just outside of London. So, you know, it's not such a scary idea. It's not hidden away in a military bunker somewhere. It's just on, well, I won't give too much more information away, but, you know, it's not such a scary idea. You can produce cannabis, you can regulate it, you can know what's in it, and we have the capacity to very much help with that in our place at Sydney Uni. So on to the trial that we did. These were the people that came into our study asking for help with their cannabis use. They were about 35 years of age. They were mostly males, 76% were men. They smoked about 23 grams of cannabis a week on entry to the study, and they had been doing so for about 20 years. And they were scoring about 12 on the 15-point severity of dependence scale, which is in the clinical area. And this is the sort of things you can do with a drug like Sativex. This is the dosing regime that we planned before we launched the study. So we can say exactly how many milligrams of THC and how many milligrams of CBD we are going to deliver to these people, when we're going to deliver it, what the dosing regime is, and we know exactly how many milligrams of the active component are in there. We took blood samples before we gave them the drug at peak dosing on day 3, and after we stopped the drug at day 6, so on day 7 we took a blood sample. Ian's already showed you no CBD in the blood before we gave them the Sativex, and it spiked afterwards. The THC in the blood, we did manage to maintain effective THC levels from those when they came into the treatment study to peak dosing on day 3, and then it dropped off as we tapered the dose off. This is an important one for the doctors who want to know, if I give medicinal cannabis out to people, are they going to have any withdrawal when they come off it? The answer is no, because in our study they didn't experience any withdrawal when they stopped the drug on day 6. You would see a sharp kick up in that green line at the bottom if they did. They also were not more intoxicated than those on the placebo, and they did not know what they were on. So the graph on your left is the testing the blind graph. So you can do this sort of thing when you do a double-blind randomized controlled trial. You can, at the end of the study, you can say to them, do you think you were on the Sativex or the placebo? And that graph shows you that they didn't know. A lot of the people on Sativex thought they were on placebo. Good number of the people on placebo thought they were on Sativex, and most people said, I just don't know. Adverse events, we scored as well, no difference between placebo and Sativex groups. So that's pretty much it, and just to draw it to a close, I'll summarise by saying preclinical evidence, anecdote, and individual experience is simply not enough to get medical cannabis validated in the eyes of the authorities. Whether you like that or not, I'm not the one making the rules. That is just the way the system works. It's not enough. You need to do formal clinical trials. There is a well-accepted, formal, structured evidence hierarchy for bringing a drug into accepted medical practice. The hierarchy is designed to minimize bias in assessments and to give unequivocal answers about whether and how a drug works for a particular medical condition. Without this evidence in place, you can't expect doctors to be trained in cannabinoid medicine. Sydney University has a dedicated team of research-intensive psychopharmacologists, doctors, and clinical trial specialists with experience in conducting clinical trials of cannabinoid administration in humans in New South Wales. We want to help. We want this institute to take place. We hope we can be involved in it. We want to have a place in Australia where you guys can interact with the scientific community and turn your anecdote and case studies into the type of language that is needed to get this thing moving forwards. And on that point, and on the point of the Institute for Medical Cannabis, or the Institute for Cannabinoid Research that we are advocating for, I will finish by pointing out that there are 3 federally funded anti-drug centres in Australia: the National Drug and Alcohol Research Centre, the National Drug Research Institute over in Perth, and the National Cannabis Prevention and Information Centre. However, there are no federally funded or state-level funded medicinal cannabis institutes, and we would like to see one. Thank you.